Hi, we can see the slide now.
Okay. Okay. All right. Well, hello everyone. My name is Rachel Larson and I'm a stroke neurologist at OHSU. And today I'll be talking to you a little bit about cryptogenic stroke. We'll focus on a review and some updates on evaluation and management. These are my disclosures that are relevant to this talk. So our stroke neurology group does receive some research grant funding from Bayer through the Oceanic Stroke Trial, and then also from Aquatech Holding for a PFO closure trial called Aquaplex. These are my objectives for today. So we will define cryptogenic stroke and embolic stroke of unknown source, differentiate between stroke etiologies using the TOAST criteria, review the yield of testing in the cryptogenic stroke workup, and identify current and future testing that might reclassify cases from cryptogenic to a better defined etiology. So the incidence of stroke is going down as we identify patients who are at risk for stroke and improve both the primary and secondary prevention. But the prevalence is increasing in upper middle income countries because of an aging population. So the population continues to age. The percent of patients over the age of 60 in Thailand currently is 22.8%. And it's expected to rise to 38.3% by the year 2050. And the mean age of first ischemic stroke in Thailand is the age of 65, with stroke being a major cause of death and disability, which we measure in disability-adjusted life years, which equals years of life lost plus years lived with disability. So in a public health assessment that was performed in 2011, stroke was ranked as the leading cause of reduced disability-adjusted life years in women in Thailand, and the third leading cause in males. So in summary, with a larger proportion of our population living past the age of 60, the mean age of first stroke onset being age 65, and this being a disease with very high rates of death and disability, we can expect that the stroke care is going to create a really significant burden on our healthcare systems in upcoming years. So why does identifying the stroke etiology matter? So identifying the correct stroke etiology helps us to provide more targeted evaluation for our patients and ideally more effective treatments. And this ultimately leads to reduced morbidity, mortality, and more improvement in quality of life for our patients. Additionally, it helps us to conserve our resources such as space, staff, and time, and reduce the economic burden both on the patient, the hospital, and the social welfare system. So let's talk a little bit about how we can identify the correct cause of stroke. So the most widely utilized system for stroke classification is the TOAST criteria, as you probably know, which provides basically non-overlapping definitions for 5 potential stroke etiologies. And these are large artery atherosclerosis, cardioembolism, small vessel occlusion or lacunar infarcts, stroke of other determined etiology, and then stroke of undetermined etiology. And this talk is going to be focusing on stroke of undetermined etiology, also known as cryptogenic stroke. And as you can see here, this category of stroke makes up about 30% of all types of ischemic stroke. Unfortunately, there are really multiple varying definitions of cryptogenic stroke, and in developing a consensus definition really requires an agreement on what is considered to be a complete workup or diagnostic evaluation, and what findings on the diagnostic evaluation are considered truly definitive in identifying an etiology. So today, there are multiple other definitions that exist, and we'll review a couple of those later, but today we'll focus on the TOAST criteria, and this defines cryptogenic stroke as a stroke that is due to undetermined etiology by either an incomplete evaluation, a negative evaluation, which is also called embolic stroke of unknown source, or ESIS, or when two or more causes of stroke are potentially identified. So we'll start by looking at what does it mean by a complete evaluation. So the TOAST paper itself actually acknowledges that a large number of tests are needed to correctly classify patients, and that this is potentially a significant problem. So what we really need to do is identify patients, which tests are going to be the highest yield in our specific patients. Many existing definitions and guidelines define cryptogenic stroke evaluation as including kind of a minimum criteria of having some form of arterial imaging, at least 24 hours of rhythm monitoring, and echocardiography at minimum, as well as a lipid profile and hemoglobin A1C. But they don't really specify what type of arterial imaging is required. They don't address non-stenotic atherosclerosis. They don't specify how long we need to monitor for cardiac arrhythmia or the relevance of the atrial fibrillation burden. And then in terms of echocardiography, we find in the studies that the yield of testing for management altering findings is actually relatively low. So if these tests are unrevealing for a source, most definitions will say that the etiology is embolic stroke of unknown source until proven otherwise. So it's ultimately left up to providers to determine how aggressively to pursue workup. Patients with, we'll kind of talk now a little bit about how we work up patients with negative evaluation or embolic stroke of unknown source. And these make up about 50% of cryptogenic stroke. So the 2017 systematic review published in Stroke used the following criteria for a diagnosis of ESIS. So one, ischemic stroke detected by CT or MRI that is non-lacunar. So they did have an imaging requirement. Absence of extracranial or intracranial stenosis greater than 50%, luminal stenosis in the artery supplying the area of ischemia. Absence of cardioembolic source of embolism, and then no other source of stroke identified. So no arteritis, dissection, migraine vasospasm, or known history of drug use. And current clinical practice is to treat these patients with antiplatelet therapies. So things like aspirin, clopidogrel, or ticagrelor, per the point chance trial or a Thales trial, and then de-escalating to antiplatelet monotherapy. Unfortunately, every year, 4 to 5% of patients with ESIS who are on adequate antiplatelet therapy do suffer recurrent stroke despite being on what current guidelines suggest is appropriate treatment. But with advances in imaging, monitoring, and our understanding of the existing etiologies, many cases that we used to categorize as ESIS may be better classified in a new category. So as treatments for these distinct etiologies become more nuanced, it's even more important to correctly identify the right etiology. So how extensive of a workup should we perform? So today, for each TOAST etiology, we'll kind of reevaluate the current workup, opportunities to reclassify patients into more specific kind of bucket, and then we'll talk about some up-and-coming evaluations and treatments on the horizon. We can start with large artery atherosclerosis. So We'll focus on arterial imaging, and I apologize, some of this may not be as applicable in Thailand, as I know you guys do a lot more MRI than we do, and do vessel imaging up front on a lot of your patients. So I apologize if some of this isn't applicable, but we'll do our best. So basically, the two takeaway points related to arterial imaging that I want to cover is that arterial imaging is that carotid ultrasound does not provide adequate evaluation of the vessels because it does not include intracranial circulation. And that's something that we see a lot in our system is folks just getting carotid ultrasound without capturing the intracranial vessels. And then in terms of kind of up and coming, vessel wall imaging is probably going to be the next step in our ESIS evaluation. So at our institution, carotid ultrasound is mostly obtained as a follow-up to CTA in patients who have extracranial carotid artery disease, but we don't feel that it's a sufficient evaluation for patients with stroke or TIA because it doesn't capture the intracranial circulation. Many of our local referring centers will only obtain carotid ultrasound because of concerns about contrast, exposure, or access to imaging, and but we feel that CTA has several benefits that carotid ultrasound can't offer, namely that it captures the intracranial circulation and it better captures the posterior circulation. And again, the main perceived drawback is risk for contrast-related kidney injury. And capturing the intracranial circulation is really important because many patients suffer from intracranial atherosclerotic disease, and identifying icad is really important because it significantly changes management. So the SAMPRIS trial, stenting and aggressive medical therapy for preventing recurrent stroke and intracranial stenosis, showed that patients presenting with symptoms localizable to an intracranial vessel with greater than 70% stenosis had a lower rate of recurrent stroke with DAPT for 90 days when compared to historical controls. And this recommendation is supported by the current AHA guidelines with a 2A level recommendation. But identification of icad may become even more important as new data emerges regarding management of these patients. So the current guidelines suggest that in patients with symptomatic intracranial stenosis, that they should be treated with aspirin preferentially over warfarin. However, ongoing studies reevaluating the benefit of adding anticoagulation in icad do exist, and we're actually currently enrolling in a study called Captiva. It stands for Comparison of Anticoagulation and Antiplatelet Therapies for Intracranial Vascular Atherosclerosis. And the question that they're trying to address is, in icad patients with greater than 70% stenosis, does the addition of a DOAC to standard of care antiplatelet therapy result in lower rate of recurrent stroke compared to standard of care antiplatelet therapy alone? So capturing icad with CTA changes management by potentially extending the course of dual antiplatelet therapy from the typical 21 days for point chance to the 90-day course recommended through SAMPRIS. And then ongoing trials are investigating the benefit of adding DOACs in these patients. A concern about obtaining CTA that's commonly raised at a lot of our telesites is the risk of contrast-induced nephropathy with obtaining a CTA. But this study, published in Stroke in 2007, kind of investigated this question. It was a retrospective study of 224 patients undergoing CTA head and neck to evaluate for acute stroke, and it showed that only 3% of patients met criteria for radiocontrast nephropathy, and none needed dialysis. So kind of suggested that the risk is relatively low and that the severity of kidney injury is generally pretty mild. So while CTA is beneficial for looking at the degree of stenosis, it doesn't fully capture plaque composition. And so we're looking at T1 fat-suppressed MRI to better evaluate plaque composition, and thinking that this may become a more routine part of the cryptogenic stroke workup in the future as more data emerges. Current guidelines on diagnosis and management of large artery athero focus on degree of stenosis, and less than 50% ICA stenosis falls under kind of the cryptogenic stroke category if no other cause is identified. But an analysis of NASIT and ECST control arm data showed that on a 5-year follow-up, 80% of patients with stenosis greater than 50% had not suffered recurrent stroke, and 40% of patients who had suffered recurrent stroke by the time of follow-up had less than 50% stenosis. So this has led many to kind of question whether or not additional factors beyond degree of stenosis could be considered high risk for patients with large artery athero. So even though a plaque may not cause significant stenosis of the arterial lumen, it may be at high risk for rapidly progressive narrowing, artery-to-artery embolism, or plaque rupture with occlusive thrombus. And really, the most widely accepted diagnostic criteria for large artery athero under-recognizes these patients who are at risk for example, artery-to-artery embolization. So this kind of leads us to the topic of symptomatic non-stenotic carotid stenosis, or SYNC is the abbreviation. And I'd like to start by reviewing a case that was presented in this article in Stroke by Drs. Goyle and Ospel out of Calgary, Canada. So this was a patient that presented with right hemispheric syndrome, and on CT, you can see here in panel A, a non-stenotic less than 50% stenos lesion. And you can see that it has some significant irregularity, intraluminal intrusions, and that it's irregular, non-calcified, compared to here the left ICA, which looks essentially normal. On diffusion-weighted MRI, you can see here that that there are multiple scattered infarcts in the right hemisphere. The patient was started on dual antiplatelet therapy, and after this initial event, and then presented 1 year later with the following imaging. So you can see here on the CTA, the right-sided non-stenotic plaque has changed in morphology. And there are also on the follow-up CT some new areas of ischemia on the CT scan that had not been seen on the MRI 1 year previously. So in addition to irregular protruding non-calcified plaques, intraplaque hemorrhage has been identified as a high-risk feature. And this study showed that carotid atherosclerotic plaques from symptomatic patients with mild carotid stenosis were associated with an increased extent of intraplaque hemorrhage within the ipsilateral carotid plaque compared to patients with moderate or severe stenosis when they looked at the histologic findings. So also interestingly, the correlation between the extent of intraplaque hemorrhage was made that basically a larger intraplaque hemorrhage area was seen in the patients with lower degree of stenosis, and vice versa, which is kind of an interesting finding. And then this follow-up single-center comparative analysis similarly found that intraplaque hemorrhage was much more common in the symptomatic ICA, about 66%, as compared to the asymptomatic ICA, which showed 6.2%. So earlier this year, the Goyle group just did come up with a kind of proposed diagnostic criteria for symptomatic non-stenotic carotid disease. And this is kind of their working definition. So for definite sync, they define it as patients who were previously categorized as ESIS and have high-risk features on vessel imaging with changing morphology, imaging findings that are consistent with recurrent embolic strokes within a single ICA territory, and then the absence of acute or chronic infarcts in other vascular territories. And then much like, for example, the modified Boston criteria, there are criteria for possible and probable sync as well. So we can kind of review on imaging the plaque morphology that they feel may convey added risk. And these are intraplaque hemorrhage, irregular plaques without a stable fibrous plaque cap, and then intraluminal intrusions. So the first on T1 fat suppressed MRI, and this would be considered a high risk plaque. You can see the white, this area here represents the lumen, and this area that's T1 hyperintense is the area of intraplaque hemorrhage. The second main high-risk feature would be the irregular ruptured fibrous cap. So you can see the lumen is here, and the plaque kind of plaque lumen border is irregular and it's sort of obscured. That's in comparison to this plaque here, which has a nice, thick, regular, stable fibrous cap. So this would be considered a low-risk lesion. And then while CTA isn't great at differentiating between kind of a lipid-rich necrotic core and intraplaque hemorrhage, it is able to detect intraluminal intrusions, such as this one seen here. And you'll notice that this one here is not well calcified, and that's considered higher risk than, for example, a lesion that is fully calcified would be considered to be potentially more stable. And in fact, a recent systematic review and meta-analysis that was published in Stroke earlier this fall, in October, it showed that the presence of calcification in carotid plaque conferred a reduced association with ipsilateral ischemic events, but the results seem to be kind of limited in cases with higher levels of stenosis. So in these kind of non-stenotic plaques, they found that calcification was a lower risk feature, but the absence or presence of calcification didn't really differentiate the risk with the existing stenotic lesions, kind of by the standard criteria. So kind of in summary, we can kind of determine the likelihood of sync based on three main features: carotid plaque morphology with high-risk features, brain imaging showing both old and new infarcts within a single ipsilateral ICA territory, and then absence of alternative etiologies, so making sure to do a complete ESIS workup. How would we think that this new potential diagnosis might change the classification of strokes in the future? This paper by Dr. Kamel, who's kind of one of the leading researchers in cryptogenic stroke, tried reclassifying ischemic stroke patients on the basis of high-risk non-stenosing carotid plaques. They looked at 579 patients from the Cornell registry that had an anterior circulation infarct, MRI brain, and then had neck vessel imaging with MRA. And they used the definition of just intraplaque hemorrhage for high-risk plaque. And patients were assessed by a blinded neuroradiologist. And then they tried to reclassify patients into a category of large artery atherosclerosis if intraplaque hemorrhage on the ipsilateral side of the brain infarction was found, regardless of degree of stenosis. And they found that high-risk plaque was more common in the ipsilateral versus contralateral brain infarction in patients with large artery athero and cryptogenic stroke, and after accounting for ipsilateral high-risk plaque, 15.2% of patients were reclassified, and a significant number were reclassified from cryptogenic stroke to large artery atherosclerosis. And that matters for management going forward. Also interesting, a large portion of patients were recategorized from cardioembolic to multiple potential etiologies, which suggests that kind of focusing on management of AFib alone may not be sufficient. So accounting for high-risk plaques could potentially reclassify ESUS up to 15% of cases of ESUS patients. We can talk just briefly about cardioembolic strokes. The 2 points that I want to talk about are how aggressively to screen for atrial fibrillation, and then a discussion about brief discussion about atrial cardiopathy and the Arcadia results. So indirect evidence at the time of strokes suggests that many cryptogenic strokes arise from cardiac embolism, but long-term follow-up with continuous heart monitoring often reveals that paroxysmal AFib that was not apparent at the time of stroke. So screening is I think important, and the guidelines recommend that we do screen for atrial fibrillation, but they don't specify how long to evaluate. So we have several options: EKG, 24-hour monitoring, 2-week monitoring, and loop recorders. So what is the yield of these, and how long is enough to monitor for? So one study suggested that several studies have suggested that 24 to 48 hours of cardiac monitoring will detect new onset AFib in about 2.5 to 3% of patients, about 2.5% in the first 24 hours, and then if we extend it out to 48 hours, it's closer to 3%. So super high. But it's challenging to study because the yield really varies depending on the study population. So how old the patients are, what type of stroke they ended up having. This study looked at kind of usefulness of different amounts of monitoring. So it found that about 2.7% detection rate on just an admission EKG alone. That additional EKGs increased the detection to about 4.1%. 24-hour Holter monitoring extended it out to about 5%, and then 7-day monitoring around 5.7%. So pretty high detection just with the EKG alone. Then maybe nearly double at the week of monitoring. This study out of the New England Journal of Medicine Embrace group looked at 30-day monitoring and found AFib lasting greater than 30 seconds in about 16.1% of patients with a loop recorder, a 30-day recorder, compared to just 24 hours of monitoring, only a detection rate of about 3.2%. So pretty significant increase in detection with the longer term monitoring. In this paper, the ASSERT trial looked at subclinical AFib and the risk of stroke with 3 months of monitoring. It also showed a significant difference in terms of detection rate with 3 months of monitoring. Crystal AF looked at 6 months of monitoring and showed that atrial fibrillation was detected in about 8.9% of patients who had an insertable cardiac monitor, compared to about 1.4% of patients in a control group. But then we have studies like this one, which showed that even serial EKGs might be adequate in terms of identifying, detecting AFib. And I think one of the problems with the studies is that most look at AFib detection, not the burden of atrial fibrillation or the functional outcomes. So when we think about atrial fibrillation, we think about paroxysmal AFib, which is when episodes terminate spontaneously, lasting less than 7 days, persistent, being greater than 7 days and not self-terminating, and then permanent, being ongoing or long-term atrial fibrillation. And so kind of the challenge here is that patients with higher burden were more likely to capture on a short study. So if someone's having a lot of atrial fibrillation, we're pretty likely to pick it up on EKG. But if they're having really low burden, so they're having paroxysmal AFib, longer term monitoring may capture those patients, but does that even matter? So this was a recent study published in Stroke in August of this last year, looking at the differences in stroke recurrence risk between atrial fibrillation detected on EKG and 14-day cardiac monitoring. They looked at patients with new diagnosis AFib after TIA or acute ischemic stroke. The number of patients was 366. They kind of divided the patients into two groups. So there were patients diagnosed by first EKG either in the ER or soon after hospital discharge. That was 218 of the patients. And then they looked at diagnosis by greater than or equal to one 14-day continuous monitor. So either like a CO patch heart monitor, like once or potentially multiple sets of 14-day monitoring. The mean time monitored in that group was 12 days. And they found that in the group that was diagnosed by EKG, the median time to AFib diagnosis was 2 days. And for the group detected by continuous monitoring, the median time to diagnosis was 36 days. And they followed the patients for 1.8 years, looking at a primary outcome of recurrent ischemic stroke. And they found that recurrent ischemic stroke occurred in 16 of the patients with diagnosis by first EKG, as opposed to only 2 patients diagnosed by cardiac monitoring. And so this suggests to me that, and when they did the analysis, time to event analysis, accounting for differences in the groups, the study population, and the use of anticoagulation, EKG had a 5-time higher adjusted risk for recurrent ischemic stroke compared to the prolonged monitoring group. And so this suggests to me that the burden of atrial fibrillation really matters, and it's not just about detection of AFib. And then also, just as an aside, we all know that AFib is much more common in elderly population. 70% of patients with atrial fibrillation are aged 65 to 85. This study kind of looked a little bit more at the specifics, and it showed that the prevalence in patients 65 to 69 was about 6.4% compared to in patients over the age of 85, it was around 28.5%, much higher in the older age group. So I think it's likely appropriate to screen very aggressively in our older patients who are more likely to have higher AFib burden, but pursuing multiple, long-term continuous monitors in a younger patient who probably just has paroxysmal AFib or potentially even provoked AFib from being in the hospital and being sick might not be a super high yield cost effective or even really relevant in terms of their stroke risk. And then next we'll talk about kind of some things on the horizon. One of the topics that's popular right now is the concept of atrial cardiopathy. We've had multiple studies looking at the question of whether or not patients with embolic stroke of unknown source should be anticoagulated. The HORSE trial, Navigate ESIS, Respect ESIS, but so far none of them have borne out that there's benefit. But a more recent study has investigated kind of whether or not there's benefit in a subgroup of ESIS patients with signs of atrial cardiopathy. And this is the Arcadia study, so atrial cardiopathy and antithrombotic drugs and prevention after cryptogenic stroke, or Arcadia. And our site was one of the enrolling centers for this trial. And the hypothesis was that in patients with embolic stroke of unknown source and atrial cardiopathy, apixaban is better than aspirin for prevention of ischemic stroke, and that the benefit would increase with the severity of atrial cardiomyopathy. For inclusion-exclusion, we included patients with greater than or equal to age 45, an existing diagnosis of ESIS, and then they defined atrial cardiopathy by 3 biomarkers, so NT-proBNP, P-wave terminal force, and left atrial size. And I think an interesting point that was made at the recent presentation of the results was kind of how many patients were qualified based on each of those factors. Most of the patients were qualifying for the study based on the BNP and the P-wave terminal force, not on the left atrial side. And then exclusion criteria were mainly to ensure that the patients were actually ESIS patients and didn't have another etiology to explain their stroke. And then there were several exclusions to promote safety. So they excluded patients with history of ICH, with elevated creatinine, chronic anemia, thrombocytopenia, and major bleeding. And so these were the results. So again, they looked at patients with embolic stroke of unknown source and atrial cardiomyopathy, and then performed a double-blind randomization. And the randomization period was pretty large. It was within 3 to 180 days of the last known well. They looked at 1,000 patients, randomized to apixaban versus aspirin, and followed them for 1.8 years, and looked at the primary outcome of recurrent stroke of any type. And unfortunately, we found that apixaban and aspirin were equal, having equal rates of recurrent stroke, so around 4.4% in the study. There was a slightly increased rate of all-cause death in the apixaban group, but this was not clinically significant. You can see was not significant. You can see the confidence interval across the boundary. They also looked at symptomatic ICH, which was actually a little bit higher in the aspirin group, and major non-intracranial hemorrhage, which was about equal in both groups. So unfortunately, so far, no studies have really demonstrated clear benefit of anticoagulation over antiplatelet therapy for secondary prevention. And then quickly, we'll just go through stroke of other determined etiology. I just want to quickly talk about some of the exciting findings that they have discovered in terms of patients with stroke that is thought to be related to cancer diagnosis. So stroke may be the initial presenting symptom of malignancy in up to 3% of patients, but we don't really know when to screen for those patients, and management is a little bit unclear. So on the horizon, we're looking at clot composition analysis, which may help us to identify cases of stroke that are related to cancer-related coagulopathy. As I mentioned, the current guidelines really provide mostly just the gaps in research, that there aren't really a lot of recommendations for the patients who have comorbid cancer and stroke. So the majority of the guidelines just talk about what's needed and don't really give us much direction on how to manage these patients. But about 10% of patients with acute ischemic stroke do have a concurrent cancer diagnosis. And in the last couple of years, a couple of groups are really looking seriously into how clot composition may help us predict patients with stroke that is attributable to a new diagnosis of cancer. And this isn't, I'll kind of skip this study in the sake of time and focus more on this study here. So basically this was a study that investigated use of machine learning in patients who underwent thrombectomy and clot analysis. It was a retrospective analysis of prospective data that was collected in the Smart Clot registry out of South Korea from 2019 to 2021. And basically they looked at acute ischemic stroke patients who were categorized as embolic stroke of unknown source and then underwent thrombectomy. And then they did preparation of and staining of the retrieved clots. And you can see that here. The platelet stain is the CD4-2B staining, and then erythrocytes were stained with anti-glycophorin A. And they analyzed two groups of patients. So group A was patients with new cancer diagnoses that were otherwise considered to be cryptogenic. They did include patients who they felt had a diagnosis of morantic endocarditis or kind of potentially cancer-associated endocarditis. And then they also looked at patients in group B who had no known diagnosis of cancer and had an established etiology for their stroke. And they found that in group A, the clots tended to have much more platelets and less fibrin, which I think is a very interesting finding because many folks are using anticoagulation to treat cancer patients rather than antiplatelet. But this study is suggesting that potentially antiplatelet could be more beneficial. You can see here the area under the curve for the external validation was, I believe, let me just double check. I think it was 0.95. And they used machine learning to kind of model the accuracy of this platelet staining model in terms of predicting the clots of patients who had a new diagnosis of cancer, and it was the machine learning was accurately able to predict the patients who had new diagnosis of cancer, even though the diagnosis was made 1 month after they were diagnosed with stroke. So these were patients who had stroke diagnosis first and then were later diagnosed with cancer. So I thought that was a really interesting study. And then really quickly, last topic was going to be on kind of small vessel disease, which you might say, well, why are we talking about that in an embolic, a stroke talk that's focused on embolic stroke? In our system, we aren't using MRI as much, I don't think, as you use in Thailand. And so I think in some cases, MRI is actually still very helpful because even though we often define lacunar stroke clinically with the classic syndromes of pure motor, pure sensory, ataxic hemiparesis, sometimes these can have overlap with embolic strokes. So, in the U.S., I'd say there are studies that suggest that over 90% of patients with stroke undergo MRI in addition to CT. And this paper suggests that they looked at kind of outcomes of death independence at hospital discharge, stroke or 1 year death at 1 year, and they said that CT alone is non-inferior to CT plus MRI. But when you look through kind of the patient characteristics, the groups who underwent MRI and the group that didn't undergo MRI were extremely different. The patients who underwent MRI tended to have low NIH, and fewer underwent acute intervention, suggesting that these were milder strokes and less likely to be large vessel occlusions. And patients who did not undergo MRI presented earlier with more severe symptoms. So, the study didn't really account for etiology or management of patients after the initial event, so it's kind of hard to extrapolate whether or not MRI played a role in their care. But, you can kind of consider two patients who have isolated left hemibody sensory loss. Patient A, you can see in the thalamus that there's an obvious small vessel stroke, but patient B would also present with isolated left hemibody sensory loss. And you can see that the management of these two patients would be really different. So if we were using clinical symptoms alone, we might miss a patient who needed a further embolic workup. Similarly, you could consider two patients with who the radiologist reported as small lacoon by size without factoring location. The patient A is a typical small vessel disease stroke, but patient B it looks more is more in like the superficial perforators, and it is probably more likely embolic. So would warrant use this workup. I'm just going to skip through a few slides here, but basically the point is that the clinical and the imaging picture may not line up, and I think having imaging gives us better opportunity to properly classify patients. And this is just kind of an additional point that lacoons can be kind of further categorized into different subgroups, and I think that as we get better at identifying which category the patient falls into, the treatment might vary, because, for example, hyaline arteriolosclerosis is usually more related to hypertension, whereas like hyperplastic arteriolosclerosis is more related to diabetes. So maybe more specific treatments depending on the subtype of lacoon. And then lastly, MRI can help us identify like really unique subtypes of lacunnar infarct and help us with prognostication and registry tracking. So this is a kind of an interesting case that was presented that is a younger patient without any significant vascular risk factors. And you can see in panel A, multifocal DWI changes. And then on the panel C and D, these are the flare sequences, and you can see that there's not a lot of significant small vessel chronic white matter ischemic changes, except here in the periventricular region. But there's no large areas of confluent white matter disease. And so because of the unusual appearance of this imaging, I think initially some might say, oh, this is an embolic stroke because it's in multiple territories and they're kind of larger size. But this group did a further evaluation of this patient because they were young. They didn't have significant vascular risk factors, and they had some of the early periventricular white matter changes. So they ended up doing genetic testing on this patient and identified that the patient had CADASIL. So while multiple acute ischemic strokes are usually cardioembolic or atherothrombotic, CADASIL can kind of have a wide presentation and can present it acutely with multifocal infarct.
Did he have any other symptom like migraine or like depression?
I think this patient had migraine and maybe some early cognitive changes as well that pointed them.
Other symptoms.
Yeah, because the flare imaging on this patient is interesting because it doesn't have significant temporal involvement. And I was reading too that in Asian populations, the temporal lobe involvement isn't as common, was what the literature was saying. So that was kind of I thought interesting. It said that the sensitivity and specificity for diagnosing CADASIL with the anterior MRI lobe white matter changes on MRI was like 89 to 86%, and then but that it was lower in that involvement of the temporal lobe was sometimes absent in Asian CADASIL populations. So I thought it's important to I thought this case was interesting because it kind of reminds us to include CADASIL on the differential when we're seeing kind of multifocal infarcts, even though this is kind of an atypical presentation. And just as kind of an aside, there was a new scientific statement that came out just this year with kind of new classifications of the different types of small vessel disease. And like you mentioned, they suggest testing for Notch 3 in patients without significant vascular risk factors and with the history of family history and history of migraine and cognitive changes. And so kind of at the we've talked about incomplete evaluations, negative evaluations. What about when two or more causes are identified? We'll just talk about one of the new schemes that's being used to better capture patients in this category, and it's the causative classification of stroke, or CCS. And this was the paper that they published. But basically, it separates out into level of confidence for each of the different TOAST criteria. So it still has a category for cryptogenic stroke, but then for each of the other stroke mechanisms, it has evident, probable, and possible categories. So this would be a way that we could potentially capture those patients with the sync that we were talking about earlier, would then fall into this possible category. So maybe manage differently in the future once testing, they've done studies on carotid endarterectomy or something in these patients. And they have it for each of the different categories. And there's actually, if you go online, there's actually a kind of a registry where you can go in and check the boxes that fit your patient, and it will create kind of a prediction of which category the patient falls into. And it's actually, I've tested it on a few of my patients, like what I would categorize them on, and then what the kind of application predicts, and it's pretty good.
It's the application.
It's just on, I want to say it's out of Harvard. You just look up causative classification system for ischemic stroke, and it's just an application that they've developed to help categorize ESUS patients. And it may be helpful for, potentially areas where they don't have a neurologist to be able to use that to help categorize. So yeah, for cryptogenic stroke, I think the main kind of takeaway points, we're trying to capture these patients, making sure that they have completed at least the standard testing. If they fall into the category of ESUS, considering some of these extended tests. And then if there's two or more causes identified, my strategy has been trying the least invasive treatment first. So if they have AFib and a PFO, obviously I'm going to treat the AFib before I'm going and doing a PFO closure or so this is a picture that I took from the hospital at OHSU.
Thank you so much. I have 3 questions for you. First, about cryptogenic. I learned many years ago about the professor from France. They think that cryptogenic stroke you need to evaluate aortic arch plaque. What do you think about the CT scan, CTA? Do you include the aortic arch? The first, second. And the second question: how do you treat non-carotid, non-asymptomatic, non-static carotid stenosis? How do you treat this patient?
Yeah. I think we're kind of in the early stages for both of those findings. So for the aortic atheromas, I've read some studies where they've gone and done embolic, like basically thrombectomy of the atheroma, but we don't do that at our hospital. It seems very, very high risk.
So you include in your registry, I mean, you include the aortic arch in your CTA.
I think it usually is captured, but we aren't really, we don't really have anything to do for it. Usually we're just doing kind of standard large artery management. So dual antiplatelet for 21 days and then, going down to antiplatelet monotherapy. I don't know of anyone who would do that at our institution. How have they been managing it here?
I'm not sure.
Nah.
maybe do antiplatelet.
Yeah. And then this, for the sync,
Yep.
I think at this point it's mostly research based, but some vascular surgeons are considering doing endarterectomy for those patients, but not at our institution.
So why the patient have vulnerable part on non-vulnerable part? Maybe caused by metabolic, smoking, or environment factor. But what do you think about the cause of the
plaque hemorrhage and
cause?
what makes it a high-risk plaque? I'm not sure. I think it's an early indicator potentially too of future stenosis. So it's like probably the same risk factor, some of the same risk factors, but just capturing it more early.
You have any test like the high CRP?
Sorry to interrupt.
One study of the going to put in the colchicine to reduce the inflammation from Australian.
The uric acid prevent. Yeah. I know my partner is very interested in uric acid in stroke prevention, but yeah, we don't know. Yeah, still waiting.
Thank you.
Yeah.
Hi.
จานมีแล้ว
Sorry to interrupt ค่ะอาจารย์ we are over time already and we still have one more talk by Sarah for the nursing team. Can we continue your question during lunch?
Okay.